we already feel welcome, courtesy of Malvin, our secretary. So, how do I start? I have two microphones. One is for you, and this is for recording. Sawa sawa. So let it not look strange, eh? So because we are recording this for our profile, okay? So, like he has said, my name is Joseph Watundu. I'm representing Life Plus, and with me I have a team that will help us to facilitate this day. I want to remind you that we're here for basically support, not any other forum. It's not a political forum. So basically we're here to learn basically support, and we'll be here for the better part of the day. So very briefly, I'll go through the team that I have so that you can put a name to their faces, and then we can kick the ball rolling. So most of them are on my right. So you stand as I recognize you in the presence of our extinguished guest. On the extreme left is Gashanja. Gashanja, you can wave to the delegates, okay? And then we have Martha. Martha there, she will be doing most of the recording. She has also passed on a form that you need to write your name. That name will at least authenticate the attendance with the list we already have, okay? And then we have our own John Makanga, an upcoming doctor. Thank you. Wave to the delegates, sir. Thank you. And then on my right here, I have James. James, okay, one of our instructor. And then we have also recording going on. We have photography. Collins, can you wave? Okay. He will be doing your photography. You can speak to him at some point, I know. And then you have Gabriel, who is doing the main streaming. Gabriel, you can wave, okay, to the delegates. I have more two. One is called Evans. I can't see him around. And our main facilitator or main lecturer, none other than Dr. Marion. Dr. Marion, you can wave to the delegates. Okay. Melvin has already spelled out the entire program. We shall have a break at around 10:30. We will guide you on how long you take the break, then we come back. The shorter we minimize the breaks, the better for us to finish on time. Should we drag on, maybe we'll have to stay here up to around 7. Sawa sawa. So with those few remarks, I believe you all got the notes, and you have gone through the notes. It would be very important because we are going to be a little bit faster. There will be an assessment, a theory assessment that will be given, and there's a pass mark. I hope Melvin and John told you that, a pass mark of 80. Are we still on mic? A pass mark of 80. So if you didn't read, you may have some challenges, okay? So here we are just going to brush through, and then we get into the practical aspect of it, which is the most important. Okay, so if you didn't get those notes, it will be a challenge for you. However, maybe you're smart, it's a smart generation, you could pick up from the lecture. So with those few remarks, let me leave the ground for none other than the beautiful soul behind me, Dr. Marion. Most welcome.
Good morning. I'm not sure which groups we have. Which groups do we have today? We have students, yeah, MBCHB, yeah, BFAM, BDS, BFAM, eh? Any qualified interns, medical officers? All right, so it's a group of students. Senior, junior, clinical or preclinical years? Clinical years, eh? All right, that's awesome. I was a publicity secretary for AMSUN, eh? Back in my day. A long, long time ago, almost 10 years ago. Yeah, so it's nice to be back. It's nice to see that things still happen as they used to happen back then. So welcome to the session. I hope everyone can hear me, because it's harder to hold the two mics. Yeah, so my name is Dr. Marion Muli. I am an EMS instructor as well as a medical officer. I am a consultant trainer, yeah, not necessarily attached to Life Plus, but happy to be working with them, yeah. So today is about basic life support, yeah. So has any of you ever done a resuscitation? Ever seen someone collapse, had to do CPR, chest compressions, anyone? Clinical years? Hakuna mtu amecollapse pale KNH? Eh? Nobody. Munaenda kweli? Munaenda KNH? Ama you are banned? I saw the memo, eh? Guys were banned from going to those places. Anyway, all right. So basically, what basic life support is about, yeah? Even before we start, even before we introduce so much of, you know, the theory. Basic life support, it's basic, yeah? What is basic? What is basic? I don't know your name, so guys will just have to volunteer yourselves. Eh? Please, what does basic mean in terms of life? What do you think it means? Somebody can volunteer with your hand, please. Yes. Yeah, yes, it's bare minimums, yeah? Yeah, basic is bare minimums, yeah? So in terms of life, what are the bare minimums? What are the bare minimums for life? Breathing is a bare minimum, yes? Circulation is a bare minimum. What else? I mean, you can breathe, amasindio, and your heart can beat. What else is a bare minimum? Your what? Your airway? Yeah, sure. Airway is a bare minimum. Yeah, you can't breathe without a patent airway. What else? So we are breathing. The heart is beating. What else must function? The brain must function. Yeah. So that is what this basic life support is about. It is about the basics that keep this patient alive until the advanced things come in. Sindio? Yeah, so what are these basic things? Basic things is this patient breathing? Sindio? Is their heart beating? Is their brain getting sufficient blood and oxygen supply? Yeah, that is all what basic life support is about. And there are a lot of things, there are a lot of discussions, theory, other additional things around this, but that is what it's about. Yeah, and that is what we shall be discussing today. Yes, so welcome to the session. I hope we shall all participate. Excuse me, someone for the setup. I don't know why it's not reflecting on the screen. Mama tutoke kwanza.
It's okay.
All right. So this is the basic introduction to BLS, and we will be doing the American Heart Association format, yeah? So I think we can start, yeah? So the basics are, in this is a BLS assessment, okay? So in the BLS assessment, the first thing, or the most important thing in BLS is safety, okay? Yeah, so safety, danger. What is a danger to you here? If I collapse now, you're coming to resuscitate me, eh? What is a danger to you here in this room? You might fall yourself, you might fall, yes, yeah, you might get tripped. There are stairs, what else? Someone else, somebody can assist him. Yes. If there is a stampede. So you guys, if I collapse, you'll stampede. Eh? That is what he has said. Eh? So guys are running. Are you running towards me or away from me? I hope it's towards. You're running this way, out the door. What else? What else is Yeah, there's a lot of equipment. There's a lot of wiring. There's electricity. So there's a lot of things even in this room that are, please don't copy the slides. Eh? I'll change a few things, so don't copy the slides. I'll tell you what to write, okay? Yeah, so those are some of the things that are considerations for safety or for danger, right? Yes? So what would you be considering in an emergency room? What are some of the things you're considering? You're at a KNH casualty, a patient has come in, with an ambulance, with EMTs, they've been handed over to you, they were resuscitating, and the patient still has not achieved return of spontaneous circulation. What are some of the dangers you're considering? Backbenchers. Na mmevaa mask nisiwaone. Uko? Any contributions? Yes, the lady with specs. Aki, I wish we had given names. Eh? Yes. I'm looking right at you, so it cannot be anybody else. What would you be considering at the ER? What are some of the dangers? What are some of the aspects of safety you're considering? Anyone else? Anyone? So turuke. Sindio? We move on, eh? Yeah? We move on. We don't move on. Who wants to say something? You're the ones who tell me. You're the ones working there in there. So you're going for clinical situations. What are some? Yes, you want to say something. I can see you. What are some of the aspects of safety? What are some of the things that are dangers within the emergency room? Eh? So a patient has been brought in by EMTs in an ambulance. They are resuscitating and they hand over to you. Yeah. So what are some of the aspects of safety or danger that you'll be considering? If the equipment stops working, is that a danger? Is that a danger to you? It's a danger to the patient. Is it a danger to you? Thank you very much. Clap for this guy. Clap for this guy. Thank you. As one of the most important things, guys are wearing Uko PPEs and they forgot to tell us, as a healthcare worker, as a healthcare provider, the first thing you consider is PPE, which means the first thing you consider is what? Your own safety, the safety of the aider, okay? Then the safety of the bystanders, then the safety of the patient or the casualty, as the case may be, right? So the most important person is the provider. And part of the things that we consider as safety for providers is personal protective equipment, yeah? And the levels differ. You're not going to treat a pediatric patient with dehydration who got into cardiac arrest the same way you would treat a COVID patient with cardiac arrest. Not the same way you would treat who? An Ebola patient with cardiac arrest, right? Are we far from Ebola? We are not. It's right here next to us, yeah? So that is one consideration. There are other considerations. There are sharps around, yeah? There's equipment around. There's always things like this, wiring, electricity, yeah? But a lot of the time as healthcare workers, it's a routine. Anytime you see a patient, you put on gloves. So you may not even realize you're doing a BLS assessment or a primary assessment or a secondary assessment, as the case may be, right? Yeah, but so it comes naturally. But those are some of the things that you need to be really aware of. There are a lot of times where people have been exposed to diseases because of maybe sharps, yeah? So you got into a situation, it's an emergency, you forgot that you had put a needle somewhere and you get pricked and you have to do post-exposure prophylaxis and things like those, yeah? So that is aspects of safety for healthcare providers, okay? So after safety, the next thing is stimulation, okay? Stimulating the patient. Stimulate your neighbor. Stimulate your neighbor. Yes, is your neighbor responding to stimulus? What stimulus did you use? What stimulus did you use? Ebum stimulate sana nione. Let me see what weird things you guys are doing. Eh? I was not looking the first time. Anyway, fine. All right. So stimulation is using some form of stimuli to try and see if the patient is responsive, right? Yeah. And we talk about, now you see there's a primary survey and there's a BLS survey. Yeah, which is why I told you not to copy those slides. We talk about stimulation as checking response to, what is the AVPU? Checking if they're alert on their own, checking if they're responsive to voice, checking if they're responsive to pain, and then you call them unresponsive. But the BLS assessment does not have time to look for response that way. Yeah? Your aim is to ascertain as soon as possible, because within 10 seconds, you're supposed to have started your resuscitation. So you're supposed to determine as soon as possible, is this patient unresponsive or alert, right? So you have to combine these things, okay? So you approach, you've checked, the area is safe. The next thing you do is, hey, can you hear me? Sindio? Can you hear me? Okay? So you're doing the whole voice and touch together, okay? Yeah, so check for your neighbor's response that way, quickly, a quick response. Hey, can you hear me? Tap their shoulders, both shoulders, like this, okay? Yeah, so they can hear you, yeah? So if the patient is not responding, then what do you do next? You shout for help, okay? Yeah, so that would be the next step on our BLS assessment, okay? So safety is very uncomfortable. So we have safety. And you stimulate the patient. Then you shout. Okay. And aspects of shouting, what are you doing? You're shouting for help from who? Bystander. So if out of hospital, this out of hospital, it depends on scenario. So if it's out of hospital, we are shouting for help from bystanders. Yeah? But you guys are in hospital care providers. So you're shouting for help from who? Yes, from fellow qualified healthcare providers. You're shouting for help from the code team. You're pressing the code bell. If there's does KNH have a code bell now? Code thing, code system. Hey, seriously? Wait. All right. So that's the one. Eh? That's the shouting for help. Okay. So you press that thing, and then guys come. Sawa. Then, after you shout for help, now you want to go into your determination. Why did the patient collapse? Yeah. Sindio? Why did the patient collapse? Do we know? We don't know yet, okay? And the most important thing, and that's what we were talking about, basics. We said this, right? We said the patient should be breathing, they should be having a circulation, and their brain should be working. Sindio, that's what we said basics are. It is the lungs, the heart, and the brain. Sindio? So you want to determine as soon as possible, is the patient breathing? Sindio? Or is their heart beating? Okay? So if they are breathing and their heart is beating, then you have time to determine. So what happened to the brain? Sindio? Right? Why did the brain collapse if the breathing and the pulse are fine, or the lungs and the heart are fine? Okay? So if they are not, then we go into basic life support. Okay? We want to support the lungs, we want to support the heart, we want to supply the brain until the patient gets access to advanced life support. Okay? So, these are the components of basic life support. Giving compressions, maintaining an open airway, giving ventilations or breaths, yeah, and defibrillation. Sawa. So this is the BLS assessment in total. Safety, stimulate, shout for help. Yeah, and as you shout for help, if it's out of hospital, it means you are sending for an ambulance as well as a defib, okay? Then you quickly ascertain if there's breathing, if the heart is beating, and if they are not, you begin your steps of BLS, yeah? And this is everything that you will do today. There will be a lot of different considerations, yeah? A lot of different scenarios, but this is what it is all about. Come in, you check safety. I'm safe. Stimulate the patient. Hey, can you hear me? After that, help! Somebody help! Get a defib, call an ambulance if you're out of hospital care, yeah? Cardiac arrest, sorry. Then you check for breathing and pulse. And this should be no more than 5 to 10, no more than 10 seconds, no less than 5. You need to take time, but don't take too long, yeah? So check for your pulse as well while you're assessing for breathing at the same time, okay? Wow. Sawa. So fine, while they set up, check your neighbor's pulse while checking for breathing. What are you looking for? What are you looking for? What are you looking for on your neighbor? Sorry. What are you looking for on your neighbor? Breathing. What are you looking for in terms of breathing? Look at is your neighbor breathing? You know they are breathing because they are sitting there and they have not collapsed. How do you know they are breathing? How do you know they are breathing? Thank you. You can see the chest moving. Can you see the chest moving? Or the abdomen? Maybe some shoulders, kidogo. But if they are breathing like this, is there a problem? Use of accessory muscles. Yes, there's an issue there. So I hope none of your neighbors. But look, you can tell, yeah? You can tell from the way there's some chest movement, some abdominal movement, and especially if they are lying down, then you'll see it clearly. Yeah, but is there any other way to tell if they are breathing? Is there any other way to tell if they are breathing? You might feel the breath, yeah? And in the days of COVID, we moved away from feeling the breath with your cheek to feeling the breath with your hand, right? Yeah, what else? What else? Can you hear? Can you hear breathing? Can you hear? Oh, sorry, I'm not using a mic. Oh, sorry, yeah. Anyway, can you hear? You can hear breathing sometimes, yeah? But that is when somebody is breathing with some form of difficulty, yeah? Maybe they have been on some exercise for a while, yeah? So, looking is enough for the BLS assessment, okay? And that's why I'm bringing in a lot of aspects of the primary assessment so that you understand that the BLS assessment is different, okay? In the BLS assessment, your focus is to move here as quickly as possible, yeah? So ideally, this should take 10 seconds or as close to 10 seconds as possible. Sawa, yeah? So we were now checking our pulses. So check your neighbor. So which pulse do you check? Which pulse is best? Which one? Radial, carotid, central. Which one is best? Anyway, for unconscious patients, you go to the pulse that is loudest, obvious, easiest to find, which is the carotid pulse, okay? And it's usually the last to go. It's an unperipheral, it's a central, it's the last to go. Yeah, it's the one you will feel. If it is there, you will feel it. Yeah, so where do you find the carotid pulse? Mnajua sternocleidomastoid. You know, you guys, I can tell you those things. When I'm training laymen, I suffer. So it is just ahead of the border of the sternocleidos. Just over there. So you can feel yours. You can feel yours. Yeah, everybody knows theirs. Feel your neighbors. Your neighbors is the one that's hard. Feel your neighbor's pulse, but don't press for too long because we might find people collapsing because of the carotid sinuses. So have you felt your neighbors? I want you on your neighbor, not on yourself. I want guys, participate. Feel the pulse, Huko. Your neighbor. Because anyway, you will do this. But you will not do this on a live casualty. You will do it on a dummy. So it's very important to feel it on a live casualty. Have you felt the pulse? Your neighbors. Who has not felt their neighbor's pulse? Nikuje sahi. Anybody? Very good. So basically, so the reason I have talked about primary survey. Okay? So after your BLS assessment, after your basics are fine, then you can move on to other things, including the ABCDE of the primary survey or assessment. And the secondary assessment. The secondary assessment contains all those other things. What other things are the secondary assessment? What are the things in the secondary assessment? Who? Okay. Shout. You're right. You're right. What? Actually, exposure medicine is in the primary assessment. Although you are saying it's fine. What else? History, thank you. Yes, there's a history. Yeah? Things like sample or the other one. Past medical. Things change, but the things are exposed to. Okay? Yeah, so our history is one. What else? Investigation. And in resuscitation, the basic investigations of resuscitation, okay? Which do your HSMTs, which you see if you do advanced life support after this basic life support. Okay? So this whole thing is called the systematic approach to resuscitation. Which means a systematic approach to the collapsed patient. Anytime a patient collapses, start here. The basics are fine, move here and do a wider survey. Okay? And then, if you are done with your wider survey of the basics, then you do your secondary assessment and determine what else will be done. Okay? So, this is up to here is basically what we shall be doing today. Extra consideration, special consideration, and I hope that we shall follow. Okay? Good. Any questions? Any questions? All right. How does this close? Yeah, it's not that. I was also actually looking for. It's not the type that closes. So I've skipped some slides because we've talked about those things. All right, so this is the AHA chain of survival, okay? And the chain of survival means this patient is not going to stay in one place, right? They have to move from one place to the next, okay? Yeah. So in out of hospital life support, what is the most important thing? Second row, what is the most important thing for out of hospital life support? What is the most important thing for out of hospital life support? For this patient to do what? To get help, not from bystanders, but from who? Advanced or trained healthcare providers. So the most important thing is recognition and activation of the emergency system. Sawa. Yeah. Now it is important for both, but its role in out of hospital care is really important, because if you delay calling the ambulance, there is no amount of CPR that you can do that is likely to restart the heart, unless it was choking, drowning, or maybe a pediatric collapse due to something obvious. Sawa. There is no amount of resuscitation that you will do that might bring this patient back. Yeah, so they need to get to advanced life support. And they will only get there if we activate the emergency system early, okay? Then immediate high quality CPR, okay? Then rapid defibrillation, basic and advanced emergency medical services, and advanced life support and post-cardiac arrest care, okay? So that's what it's about, basically. Recognize and activate EMS, start your high-quality CPR, defibrillate as soon as possible, so early defibrillation, okay? Basic and advanced emergency medical services, which means you've called an ambulance and it is on scene, okay? Then advanced life support and post-cardiac arrest care is what is in the hospital. So EMS came, EMS moved, and they've also handed over to the hospital. So it's a chain, is it not? Good. For in-hospital cardiac arrest, what is the most important thing? In hospital means the patient is admitted. Mnaweza copy, here it's obvious. Mnaweza copy. It's the first chain there. It's the first chain link. It is preventing the arrest. You don't want this patient to arrest, because if they arrest and they were already so sick that they are admitted, then how likely are you to be? It's not very nice, eh? So start with surveillance and prevention, preventing the cardiac arrest. Yeah, you're doing daily UECs, BGAs. You know, you're doing a full hemogram. You're treating. You're seeing that the patient is improving. The patient is on a monitor. Yeah, you're always seeing what this patient is happening to this patient around the clock. Yes. Then recognition and activation of the emergency system. So in this case, the emergency system is the bed. Is it not? Is it in the hospital? Yeah. Good. So, any questions about the chain? So this is what we have talked about here in a nutshell. So verify scene safety. If the victim is unresponsive, shout for nearby help. Activate emergency response system via mobile device, get an AED and emergency equipment. And we shall interact with an AED today until Tosheke Nana. Then look for, and what's an AED? Sorry. Because I'm just saying AED, yeah? I'm just saying one thing. It's a what? A what?
An automated external.
An automated external defibrillator. Automated means you only need to turn it on. External means it defibrillates from the outside. It's a defibrillator. What does what is fibrillation? What are fibrillation? Yeah, that quivering of the heart muscles, okay, yeah. And fibrillations, I mean, I teach advanced life support as well, so yeah, but it is insufficient to provide sufficient or what? Perfusion to the main organs or to the vital organs. Yeah, so the role of the AED is to defibrillate, to stop those fibrillations, so that the heart does what? Beats, starts beating normally. So what it does is it stops the heart. That pulse stops the heart. So when you defibrillate someone with a manual or automated defibrillator, what have you done? You have stopped the heart. Is the heart beating? Must it beat? Yes. So what does that mean you should do? Immediately you defibrillate. Start chest pump. Don't start checking for pulse. You see movies. You know that I'm doing this because I've been watching a lot of medical series and movies. And what do? They defibrillate and then they or they say the pulse has come or it hasn't come. It's not, you're not going to see any electrical activity. Yeah? So you start beating until the heart now decides to jumpstart the right way. So don't believe those guys. They're liars. Anyway, you get the AED. Look for no breathing or look for gasping. What is gasping? Yes. Stand up and show them. That is good. After your mask. Stand up. Yes. So that they can see. You know. See, Mama, those guys there can see you. So yeah. Do it nicely. She did it so nicely when she was sitting. Anyway, yeah. It's those agonal breaths, or they're just. Yeah. Has anyone ever seen a patient gasping? Yeah, there is nothing going in basically. It's like the muscles are trying to, you know, the breathing has stopped, but the muscles are trying to sort of jumpstart. Yeah? So there's that residual activity. Yeah. So that is a sign that there is cardiac arrest. So it is not to be taken as normal breathing, and resuscitation should be started. Okay. Yeah. So within 10 seconds, do you feel a pulse? If you have no breathing or the patient is gasping and there is no pulse, then you begin CPR. Cycles of 30 compressions and 2 breaths, and use an AED as soon as possible. So when the AED comes, you attach the pads while avoiding breaks in chest compressions. Okay? So once the AED arrives, check breathing. Is it a shockable breathing? Yes. Give 1 shock, resume CPR immediately for about 2 minutes, then, so the AED prompts you. So once the AED comes, resuscitation becomes very easy. Before it comes, you are counting 32, 32, 32, 5 cycles of that is 2 minutes. Yeah? So that is, the AED changes things, because now it tells you, checking for rhythm, yeah? So clear patient, so you clear the patient, it checks, it needs to shock, we tell you to press a button to deliver the shock. Okay? So if it is not a shockable rhythm, resume CPR for about 2 minutes. Okay? Yes, so it's a lot of theory, and a practical would be better to show you. Okay? But what is the rate of chest compression? No, the number is 30. What is the rate?
100 to 120.
Yes, 100 to 120 per minute. Okay? So what is 100 to 120 per minute? It's about 2 per second. Okay? So it's about this. 5, 6, 7, 8. So they say you sing staying alive, but everybody sings things differently. Yeah? So it might be that's still staying alive. And staying alive. That's still staying alive, is it not? Yes. So what is this rate of the singing? Yeah. But anyway, staying alive, staying alive. So you guys will do the practical. I will not be there, but basically that is. So it's a rate of about 2 compressions per second, and that's how I like to think about it. Because if I'm thinking about it like that, and I'm thinking about it as Kenyatta 1, Kenyatta 2, you get, that gets harder to count when you're doing that. Yeah. So that is the rate, 100 to 120 per second. Yeah. So you deliver 30 chest compressions at the rate of 100 to 120 per second. Push hard and fast. Okay. Yeah, and for every 30 compressions, then you get 2 rescue breaths. Okay? All right. So if there is no breathing and the patient has a pulse, you provide rescue breaths only. So in hospital cardiac arrest, you have equipment, right? So equipment gives you the ability to bag the patient, the ability to intubate the patient in advanced life support. Okay, so you bag the patient, giving 1 breath every 5 to 6 seconds. Or about 10 to 12 breaths per minute. Okay? So Kenyatta 1, Kenyatta 2, Kenyatta 3, Kenyatta 4, Kenyatta 5. Kenyatta 1, Kenyatta 2, Kenyatta 3, Kenyatta 4. So, what is the typical bagging rate? How do we bag patients? Have you seen patients being bagged? At the AED? How do they bag? So what are you doing? You are just overinflating those lungs, you are bursting alveoli, you are putting air in the abdomen, because the airway is full, some air mass. How do you breathe? Do you breathe like that? The way we bag patients. Bag patients the way you breathe. When you need to take a breath, bag the patient. Right? Yeah? So don't bag patients like this. Nobody is breathing like that in this room. Yes? So you want to breathe for the patient the way they should breathe for themselves. Okay? So activate your mind, continue rescue breath, and if possible, you can look for these other extra causes. Okay? Now these other extra causes are not part of BLS, but they're important. For example, if you know they took drugs No, they took an organophosphate, yeah? Then you're thinking about atropine, you're thinking about pralidoxin, yeah? If you know they took an opioid, you're thinking about naloxone, yeah? But those are extra, they are actually parts of advanced life support. But as a person providing DLS, who is trained in all these other aspects, and these are some of the things you might want to look or think about, okay? And then if they have a breathing and a pulse, you maintain the airway and you monitor them until emergency response arrives, okay? So how do you maintain the airway? While maintaining good circulation to the brain. To maintain good circulation to the brain, somebody needs to lie down. That's why we faint when we stood for too long. So they're lying down. But how do you keep the airway open? Like they might vomit. Yes, this is how we open the airway, which we'll see later. But they might vomit, so how do you? You put them in recovery position. Well done. What is recovery position? Stand up and show them. You know recovery position? You have a rough idea. Yeah, stand up and show them your rough idea.
So once they're lying, you put them to lie on their side, and then then you start again. So they're lying on their back, and then you push them to the side with one leg, pushing it to the side, and then the hands are kind of like this, so whatever will be blocking their air can be smooth.
Yeah. So basically, thank you. Clap for her, please. So, recovery position is basically just about having the patient on the side, so that if anything comes up from the airway, then it can come out as opposed to going into the, if it comes up from the abdomen or from the stomach, it can come out instead of going into the airway. Yeah, so that is how for BLS you maintain an open airway. You put the hand nearest to you on the ground, put the other hand on the cheek for a pillow. I hope I don't fall. You raise that leg and use it to pull the patient to the side. So they end up lying like this. Okay? So that's that. So if anything comes up, then it comes out. So you monitor vitals until emergency arrives. Okay? So let's quickly go through those safety things. So confirm safety and victims. Yeah. Use barrier devices. So use PPE and do not risk your life. Yes, do not go into a burning building. Do not go resuscitating an Ebola patient because you love medicine and it's your passion. People like telling us about passion a lot. Stimulate the victim. Okay, so tap them, ask them, are you okay? Can you hear me? Call them by name. So ask them if they're okay. If you know their names, tap or shake the shoulder. So you're doing this at the same time. You can inflict some pain. Yeah, you can inflict some pain on your neighbor. Inflict some pain on your neighbor. So why are you pinching people, honestly? So you can use the yellows, you can do a sun on rub, but ideally, you are avoiding doing a sun on rub on someone who is just sleeping. So those are, again, also aspects of actually the primary assessment. A, B, C, D, E, okay? Yeah, so just stop them, shake them. If they are not waking up, do what? Move on, okay? Shout for help. And then, after you shout for help, check your breathing and pulse, okay? Then start your resuscitation. It is as easy as CAB, compressions, airway, and rescue breath, okay? So we did this, check carotid pulse. So where do you give CPR? Or where do you give chest compressions? Where do you give chest compressions? Where? You can read, you can copy. I'll put it there. Center of the chest, okay? Lower half of the sternum. So find your sternum. Where is your sternum? Touch the lowest point of your sternum and the highest point. So where is halfway? About here. Yeah? So you place your hand on, this is where the bulk of the heart is. Where is the heart? It's on the left. After you did anatomy. You realize the heart is where? It's at the center. There's a line here. There's no space for a heart. There's space for a heart here. There's a line. Is there no line on the left side of the chest? Good. So the heart is here, okay? It tilts more towards the left, bigger on the left side, yeah? So there is that impression of the lung, the cardiac impression, right? But otherwise it is at the center of the chest. And the bulb, or the ventricles, which is what you want to focus on, is on the lower half of the center of the chest, which is where we place our hand. And one easy way to locate, because you'll not start doing this to a patient, is just to put your hand in the patient, armpit of the patient and bring it to the center. So do that. So that is where you should be giving your chest. Just armpit to the center. Okay? That's enough. Yeah. Good. So CPR increases perfusion of the heart and the brain. We've talked about these things. Yeah. And our aim is not to give 100% oxygen. Senior, how many patients do you find with 100% oxygen? Do you find patients with 60% oxygen saturation who are alert and awake? Yes. Those COVID guys used to come with those stats. They used to come with those stats and they are alert and awake. But if there is no circulation, there is no alertness or awakeness. So even if it is 60% O2, because they are not breathing and you don't have oxygen there, yet, this patient's most important need is for whatever oxygen is there to get to the vital organs. Yeah? So it's about the cardiac output more than it is about the oxygen saturation. Good. So, tushasema, hard and fast. So what is this hard? I'm a deep. What is hard? What is deep? What is the definition of deep? At least? At least a third. Okay, yeah. Saying a third is easier because people are different in size. Yeah, but we use 2 inches. At least 2 inches, or 2 inches to 2.5 inches. Okay? Or at least a third of the casualty's chest. And again, a third, when you lie down, yeah, the line where the arms are is about a third. What is this line? What is this line called? This is the anterior what? Anterior what? Axillary line. That is about a third, okay? But 2 inches, at least 2 inches, yeah? So you're compressing until the patient's chest is reaching where the arms are, okay? Good. So press hard and deep, yeah? Okay? So this is what we're talking about, ventilation, yeah? And it has other effects other than just, it will increase intrathoracic pressure, so it will reduce venous return. So what do you have? Reduced cardiac output. So you have blood glucose in the peripheries because there is so much air pressure in this chest, okay? So it reduces the chances of you getting return of spontaneous circulation, okay? So these are the airway opening methods. Now the relevance of airway opening methods, let me repeat myself. In BLS is during the opening of the airway so that you can deliver effective rescue. That is the only relevance of the airway in BLS. In the BLS assessment, in which your aim is to get to compressions as soon as possible. You heard about compression only CPR. Like you can give chest compressions only and actually still be helping this patient. So the aim of BLS is chest compression. So as you're learning today, remember. But you see, if you have the bag, or if you don't have the bag and this is your relative, and you're comfortable giving mouth to mouth, then our considerations for airway and breathing come into house. So methods of opening the airway are 2. There's a head tilt chin lift, where basically you are tilting the head and lifting the chin. You're doing what? How do you tilt? Ever tilt your neighbor's head backward? So that's how you tilt the head backward. On the forehead. So when you guys are doing the practical, please don't be touching anything else. Don't be touching necks, don't be touching straight, occiput. You can only tilt the head back by pushing it at the forehead. Yeah? How do you lift the chin? You can only lift the chin from here. Ama, you can lift the chin from anywhere. So please, it's just as simple as that. So head tilt, chin lift your neck back quickly. So it is both at the same time now. So you are on the forehead and the chin. Okay? So that is how we open the airway. And the airway is open to sniffing position. Good. So for patients of trauma in whom you suspect cervical spine injury, or in whom the mechanism of injury can lead to cervical spine trauma, then you use the jaw thrust. Okay? Now the aim of the jaw thrust is to lift the tongue off of the airway without moving the neck or the head. So the head remains where it is, and now what you need to do is to thrust the lower jaw forward. Okay? So how do you thrust the lower jaw forward? You put fingers here and you push it. Okay? So you'll do it practically, and you'll see how it is done when the patient is lying down. Okay? And once you have performed the jaw thrust, then you need to maintain that airway in a neutral position. So you can use a bystander to hold. If you're in the hospital, you can use a cervical collar to keep the spine supported. Otherwise, you don't protect the C-spine, what happens? You may find yourself resuscitating, but you cut off whatever supplies the whatever supplies the what? The breathing and heart muscle. Okay? So stabilize the spine and cervical with a cervical collar or manual. Okay? So this is it. This is a, you know this thing, yeah? You know this one. You will see it practically. What is this? What is this? It is a BVM. What is a BVM? A bag valve mask. Okay? So there is a bag. There is a bag here. There is a valve somewhere in the middle so that it is one way, and there is a mask. Yeah? So that is what that is. So when you're giving rescue breaths, thank you. So if you have O2, you can connect it to the bag valve mask. It should be transparent so that you can see if there's anything going in. Yeah. Good. And it should have a tight seal. The mask should have a tight seal. So you do these things practically. That's why I'm skipping over some of them. But if the chest does not rise, so we assumed already that there was chest rise. How do you know that a patient is getting a breath when you're pressing your bag and valve mask? Bag valve and mask. It is, you see, chest rise. Okay? So you press the bag, yeah, for about 1 second, and you see if there is chest rise. So if there is no chest rise, what do? It means there could be something blocking the airway. It could be that your airway is not well positioned, and you will see that today because our dummies are live dummies. Yeah. So what do? You reposition the head. You check, was my airway okay? And you attempt again. Okay. So if you're attempting and it's not working, and you know you post chest compressions to give this breath, if you don't have an endotracheal tube. So what do? It's not working. Go back to chest compressions. After 30, try again. Okay? So don't stay there. Hey, here Ingi, you're repositioning the airway. 10 minutes later, the brain died a long time ago. Okay? Yeah, so while the chest compressions are ongoing, you can be checking for obstructions. Okay? Yeah, and you can consider use of the oropharyngeal or nasopharyngeal airways. How? Yeah? So because you're in advanced settings, you will also be putting tubes. Yeah. Good. So this is what I was talking about. 5 cycles is 2 minutes. So every 2 minutes you're supposed to be reassessing the patient. Okay? So you're doing 32, 32, 32, 32, 32. That is approximately 2 minutes. Okay? If you have your AED attached, then it will tell you 2 minutes are over. So you will interact with it. Eh? So if there is no pulse, continue. Hide and fast 2 inches or 5 centimeters. Yeah? Not to exceed 2.4 or 6. Eh? Change tasks after every 2 minutes. Okay? So if the patient starts breathing, what do? If the patient, if you check and you find a pulse, Let's start there. If you check and you find a pulse, what do? So you are doing your chest compressions, 2 minutes are over, you assess, and there's a pulse. What do? Anybody? Ama tuanze kupeana sweet. Is that it? So if there is a pulse, you open the air, okay, and check if the patient is breathing. All right? So now you're going to your primary survey. So you open the airway and check if your patient is breathing, okay? Because the aim of BLS is to achieve return of spontaneous circulation. So circulation is the pulse only, right? So you open the airway and check if your patient is breathing. So is your patient breathing? Yes, good. So we have achieved both. Is your patient not breathing? What do you do if they are not breathing? You do what?
Support.
Yeah, you support ventilation. Then you say you give 1 breath every 5 to 6 seconds. 1 breath every 5 to 6 seconds. Good. Okay? So you support if they are not breathing. And while you're giving this support, then every 2 minutes you are still reassessing. Okay? Is the patient still having a pulse? Is the patient now able to breathe on their own? Okay? So if you have the full ABC intact, again, it is the same. Put them in recovery position if you're out of hospital. Okay? If you're in hospital, move them to the ICU. Yeah, you know. Yeah, so it is like that. Yeah. Now start doing all those other, do your primary assessment, call the relatives now, get a history. So you settle them. Yeah. Start drawing blood for things you get. So you are getting what we are doing. Are you getting what we are doing? Good. All right. So we talked about this. So these are what you need to have effective CPR. So minimize interruptions, and that's what I was talking about. Minimize interruptions in compressions. Compressions are the hallmark of BLS. I will keep saying that. Compressions are the hallmark. You need to start them quickly, they need to be effective, and there needs to be minimal interruptions between compressions. Okay? So allow chest recoil, avoid hyperventilation, switch roles every 2 minutes. Chest compression delivers small but critical amounts of blood and oxygen that can support the brain and the heart. So hard and fast, at least 100 to 120 per minute. Yeah, so we talked about this. So this is effective CPR. Yeah. So are we switching roles?
Because you can get tired.
It is exhausting. Who has ever done resuscitation? I asked, I think, at the beginning. Nobody. Who has resuscitated? You've done it. He said, how was it? Tell them.
It was tired.
It is exercise. If you do 2 minutes of chest compression, I think you burn about 100 calories. Or about a whole pizza. What's a whole pizza or a burger? It's exhausting. Hey. It's worse than jogging. So basically, you need to switch so that they can be effective. The more tired you are, the less you are pressing, or the less hard you are pressing. Yeah, the slower you're pressing. So you need to switch roles for it. Memories, I was waiting for you guys. I've seen some guys writing. You're finished? Good. So, but you have the materials. You have the manual. If you have the manual, then don't copy this thing. Sorry. Yes. So we can. All right. Great. What does this mean? What does it mean? Who knows what it means? I also don't know. Joseph, tell us. Anyway, any questions about BLS? Joseph, yeah. No, I'm not telling you. You're not telling us. We shall find out. It's the assignment, right? It's the assignment. This class. Let me just I'm waiting. All right. Great. Is that great? Is that great? So don't forget this. The systemic approach to resuscitation, you will use your entire life as a doctor. Do not forget this. And what things are important and what important. So cardiac arrest has some special considerations, yeah? Who are special patients? Special patients in Kinanani always bring special populations. Kinanani? Pediatric? Geriatric? Pregnant? So for resuscitation, trauma is also a special. Cindy, is it a special situation, trauma? They need collapse from a medical condition. They were cut and bled, and now they are. So what are the considerations for pregnancy? At 18 weeks versus pregnancy at 36 weeks. Yeah? So those are some of the things that we will discuss. Allow me to rush it because we are time bound. Okay? So cardiac arrest in pregnancy and priorities for the woman in cardiac arrest are still, this is the priority. But while you're prioritizing these compressions, then you need to consider that if the pregnancy is big enough, as in fundal height is above the umbilicus, as in it's more than 20 weeks, it might be compressing the aorta and the portal circulation, yeah? And the return of the venous or the vena cava, the aortocaval circulation, okay? Yeah, which also includes the portal circulation. So you need to relieve this compression, okay? And how do we relieve this compression? Do what?
Push the uterus. If you can palpate the fundus of the uterus, then you can push it from the left.
Yeah, so it is you push the uterus or you displace the uterus to the left. Okay? So what we used to do, kitambo, is we would place some cushioning or padding under the gluteus so that she tilts like this a bit. But what have you done now to the chest? You've tilted it. Are you able to give effective compressions? Yeah, so that's changed. Okay? So manual left uterine displacement is beneficial. Okay? So you just push. I've done in theater, when the patient is lying down, they have had the spinal putting, and sometimes they feel dizzy and the BP goes down. Yeah, so if you just push the uterus to the left, the BP comes back, you just lift it off the outer cable. Circulation, alright? Yeah. So if the patient is not going to survive, what do? Yani, you are saying there is no hope. That's what I'm saying. Or you are saying that you're giving this BLS, and in your case advanced even, you've given drugs, HSNTs, and still this thing is not coming the way you want. What do? Now, there are two people. Are they two people? There are two. Sindio? There is a mother here, there is a baby. Is the child alive?
Yes.
The child is most likely, unless the mother has been off circulation for a very long time, alive. Okay? So you're thinking about saving these two lives. So you deliver the mother via cesarean section, and while you're delivering, yeah, and trying to save this baby, what happens is that the removal of the child might improve things for the mother. Yeah? So you might have a case in which you have saved two lives. Yeah? Okay? So it is called perimortem cesarean delivery. Around mortality, cesarean delivery. Fine, you might have to find you're doing it in cases like eclampsia, yeah, where the mother has gone into full-on organ failure. You've tried to resuscitate the mother. It's not working, you deliver there, and eclampsia is a pregnant. The moment you remove the placenta, the mother, it actually starts. So those are some of the considerations for pregnancy mothers. Okay? So you should consider guidelines within 4 minutes after onset of maternal cardiac arrest. Okay? So it's an ethical issue. Is it an ethical issue? It is. Yeah, we already discussed this. Poisoning. Yeah, poisoning and other possible causes of, and giving the antidote alongside provision of BLS. Okay. Geriatrics. What are the considerations for geriatrics? Yeah, they are old. They have osteoporosis. Their bones are fragile, so they might break. Yeah. Also, it means that in their causative issues, fractures might cause, they get a lot of neck or femur, things that might cause them to go into arrest. So even in prevention, in the chain of survival, you have some considerations. Then they have a lot of comorbids. Again, this is a prevention consideration, senior, as well as a cause consideration. They are on antihypertensives, beta blockers. Their guys are on alpha blockers for prostatitis, things that slow down the circulation at the heart. Okay. Then loss of muscle tone, which means they are more prone to hypothermia. So trauma patients. So again, ABCDE is a primary survey. So with a trauma patient, like any other patient, this is a BLS assessment. If they have collapsed and they're in cardiac arrest, this is what you do for them. However, because trauma means that there are causes like bleeding that could be causing them, finding the cause of the bleed becomes important, which is why circulation with hemorrhage control is a very important aspect of trauma patients who are in cardiac arrest. So you're doing your BLS assessment, but alongside, if you're seeing a big bleed, they're bleeding and things like, what are you doing? What are you compressing? So you are just compressing to send there to the tap to keep on. So you need to close the tap before you start compression. Okay. So close the tap, apply a tourniquet or direct pressure if direct pressure works, and then continue compressions. Okay. Things like transfusion. You know, when I'm talking to medical students, I can go above you. So transfusion is another thing you're considering at this point, because you might transfuse, you increase the blood volume. Considerations of things like fluids, up to 2 liters of crystalloids. Those are some of the other extra things you might be considering for trauma patients. Good. Pediatrics, their head. What is wrong with their head? There's someone who's just like, that is true. What is wrong with the head of pediatrics? It is big in comparison to their body. So it's not big, it's just big in comparison to their body. So when you place them down, when you open the airway with a head that is like this, you actually fold the neck. So when you tilt their head back, you fold the neck. So the chin should never be here, but for pediatrics, we put the head in neutral position. So in that position, their airway is open. So the moment you've done more than that, you've kinked the airway and you have closed the airway. So consideration for kids, like any other, there is trauma, fluid, volume, and mostly that they go into respiratory arrest as opposed to cardiac arrest. So you find that the AED may not be necessary, but you should still place it, because there is that 1 or 2 where it will work, And again, for pediatrics, focuses on or being able to deliver breaths becomes important. For peds, being able to do what? Deliver breaths becomes important. Now when you do the European cardiac arrest algorithm, you actually start with breaths for pediatrics, 2 breaths before you give your, but AHA just does compressions then breaths. But focusing on, are we giving effective breaths? For peds, are we giving breaths in the first place is very important, because they tend to do more of respiratory than cardiac, But arrest is still arrest, okay? So do your thing as you should, deliver effective compressions, deliver effective breaths, place the defibrillator, So the only person in whom you do not place an AED with adult pads is the infant, because the dose for adults is too big for the infant. So babies below 1, if you do not have pediatric pads, do not use the defibrillator, okay? But for everybody else in the population, you can use adult pads. If you have pediatric pads, use pediatric pads. Other than that, the defib will do everything else for Any questions? So, near drowning or drowning. What is drowning? What is drowning? Ati? Water? Nasikia tu water. Water has done what? What has water done? What water has water? Yes, what is wrong? When water compromises life, amejaribu, ule anafanya hivi, like, so tell us the exact definition. Yes, the one who did this, I saw it in the report. Magenta. So drowning is respiratory failure or arrest due to immersion in a liquid. Is that not what it is? Is that not what it is? Good. So basically, considerations for drowning is the thing that happened first is the lungs failed before the cardiac arrest. So again, as with pediatrics, breaths become important. And with drowning cases, if you can start with breath, they're better. You find that you give the first breath, the second one, you cough up water, they start. Okay? So those are the considerations. Those are special cases where you might want to consider starting with breaths, and whether you consider starting with breaths or not, breaths become crucial or compulsory in your resuscitation process. Okay?
Sorry, yes. I have a question. So for drowning, how many breaths do you give before you start chest compression?
The ECC says 5.
5.
Yeah, ECC says 5. So we usually straddle that line of ECC and AHA. Yeah, a lot of our resuscitation is AHA based. Yeah, but ECC has a lot of breathing based things in BLS, like drowning pediatrics, where some things change. So you give 5, you see, if they do not, then you start your compressions. Okay. Good, very good. Snake bite. I want to talk because you guys don't see snake bites in Nairobi. Then when that one child is referred, anyway, snake bites are also a consideration. Yeah? And the consideration for snake bites is anti-snake venom is a part of resuscitation for snake bites. How do you give anti-snake venom? How do you give anti-snake venom? Do you know the dose? The dose is the same for adults or pediatrics. A person who has collapsed, now those things in the anti-snake venom, the readings, those venoms are all different, the way they are given. The pamphlet inside that thing tells you how to give it, okay? But it's not one vial where the snake bite is severe. Never one vial, never, okay? Start high and come low. So start with like 4 vials, yeah? For INOSAP, which is what we are using in the market now, the maximum is 4. So somebody who collapsed because of a snake bite, we are starting at, and then the next dose after 4 hours you'll give 2. The next dose after that you'll give 1. Then you continue with 1 every 4 hours until the patient improves. Okay? So giving anti-snake venom, neurotoxic venom, you just do a continuous infusion. You are just giving this patient. So it's important because in a report don't see snake bites and it baffles them when those patients come, right? So those are some of the considerations that we have as special cases. Drowning being one of the most important special case. Choking is another, but you do choking practically. Yeah? Okay. Yeah. So any questions? Maswali, iko. Mbona mnanichekelea tafadhali? It's all right, no problem. Any questions on this side? So has learning taken place? Learning has taken place. Yes. My work was to come here and tell you what you should use the whole day. So that was my work, and I hope I have delivered that. So as we go on with the classes, remember this is the focus of BLS compressions. Thank you very much.
Only the gentleman. Yes.
You had mentioned something about when a patient starts breathing. What are you supposed to do after?
So when a patient starts breathing, what do? Now things have come to normal. Eh? See, we said when they start beating, you bag. Sindio, when they start beating, you breathe for them. So when they start breathing, what do? You're in hospital. What are you doing in hospital? Resuscitate amerudi. Let me return the question to you. Sindio? Now they are breathing and their heart is beating. Sindio? Maybe they're even becoming a bit semi-conscious. What do? It's a logic thing. It's not even a thing until you think you need to be told. It's something you do every day. What do you do next? So you're moving them to hospital bed, to mostly ICU. There is no way after ROS you move the patient straight to ward. There are many other things. I'm avoiding because it's advanced life support. The things I am going to say, but basically you're moving them to an ICU bed. You're initiating advanced life support. You're doing investigations. You're treating. If there was sepsis, for example, it's the things you do every day that you now start doing. Yeah. So basically, because now the basics are back. So now we go to the advanced. Yeah.
I wanted the guys to clap. Dr. Manu, we really appreciate for creating time to come. Okay, so she has laid out everything, very flat. We want now to just slowly. We go step by step in each category. We have 3 different categories, and the following discussion is just to break it down, nothing new. If you don't mind, for the next 15 minutes before we go for break, is that okay? So we now want to digest the whole. She's given a lot of rich information. All we want is to digest slowly. So we'll go step by step for the next 15 minutes. We go for break, and then we come back. I don't know whether John told you, you have to do a registration online. Your examination is going to be online, and most probably we are doing it after break. Nothing new. What you have just said. Nothing new. And then you have the material. So there is nothing strange. It's multiple choice. So if parameter the question is out of reach, you guess and say A or B. Yeah. So John, there was only one registration yesterday successful, so probably you could share during break time so that they can register and then they can do the examination after break, because after break we go into practical session. So the next presenter is James. He will take only 15 minutes, and then we shall have John after break, another 15 or so minutes, and then we wind up with going to the practical session. So any burning question? I want to release Dr. Marion. She's going on a trip. She's a busy woman. Any question? Do not ask me strange questions. Yes, there's a question, Dr. Yes.
How do you approach a patient, a blind patient, and how do you give them CPR?
Great. So how do you approach a blind patient? So you were saying bites in the chest?
Yes.
Great. How do you approach a blind patient? Now, listen. Are they feeling pain, first of all? Are they feeling pain? They are unconscious. Are they not? See, the point of this thing is we are resuscitating. A person who collapsed. There is no pain. Now, other than severe bleeding, there are no other considerations for BLS except the basics. And the basics are to get the heart pumping or to get blood moving, to get breathing in if you are able to, right? To get sufficient perfusion to the brain. Okay? Yeah. Yeah? If you have band dressing, you might dress. Because if you dress, you're causing less damage to the burnt tissues. Yeah? So in hospital, you have a chance to possibly cover the burns, yeah? So that there is less extra damage. Okay? But if you're out of hospital, there's no other choice. It's just your gloves and those bands on that chest. People give on no skis, just direct muscle. People not open and give even direct CPR to the heart, compress the heart directly. Yeah. So, traumatic conditions outside of severe bleeding are not relevant to basic life support. Is the question answered? Am I right? No, sometimes people trap teachers. They go and look for then they come and ask you a question. So if I'm not right, tell me, no way, that's a lie. That's a lie. All right, any other? Great, so you guys, it was nice to interact. Asanteni sana for answering the question. Shall we? Look for advanced life support as well. It's more expensive, but organize a little bit. It really gives you a lot. Great, so I really.
See you.
Ask these guys. Guru in IT. Yeah, no IT. Yes.
For resuscitation of cardiac arrest patients is high-quality basic life support. It's critical that you successfully perform these skills because effective advanced cardiovascular life support depends on them. These skills help save lives. High-quality CPR maintains blood flow to vital organs, especially the heart and brain. The components of high-quality CPR include adequate compression depth. Remember to push hard, compressing at a depth of at least 2 inches. Make sure you position your body over the patient. Good body position, with the shoulders serving as the fulcrum over the chest, will help you use your own body weight to perform compressions. Consider a step stool if necessary to achieve this position. Adequate compression rate. It's important to push fast by compressing at a rate of 100 to 120 compressions per minute, allowing complete chest recoil between compressions, minimizing interruptions in compressions. Healthcare providers must minimize interruptions in chest compressions. This includes any pauses to deliver ventilations. When healthcare providers interrupt chest compressions, coronary perfusion pressure decreases dramatically and remains very low until compressions are resumed. It takes several compressions to build enough pressure to achieve an adequate coronary perfusion pressure necessary to get ROS. And finally, avoid avoiding excessive ventilation. The AHA recommends the use of audio-visual feedback and prompt devices during a resuscitation attempt or during training for real-time monitoring of CPR quality. The first skill we'll demonstrate is combining 30 compressions with 2 ventilations. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 'So, let's build on these skills. We'll now illustrate 2 healthcare providers assessing and performing high-quality BLS, including the use of an AED. And the scene is safe. Are you okay? Are you okay? We need more help. Call for backup and bring the defib. No pulse. He's not breathing. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16,
Analyzing
17,
clear.
18, 19.
Do not touch the patient. Shock needed. Charging. Stay clear of patient. Clear. Shock now. Shock delivered.
1, 2, 3, 4, 5, 6, 7. In summary, perform high-quality CPR by compressing at a depth of at least 2 inches and at a rate of 100 to 120 per minute, allowing complete chest recoil, minimizing interruptions and compressions, and avoiding excessive ventilation. Additional measures, such as switching compressors every 2 minutes or earlier if fatigued, and using audio and visual feedback devices to improve CPR quality in real time, will help give patients the best chance for survival.
Good. So I'm going to talk about So, team, let's stand up. Let's stand up. So, let's stretch. Okay. Okay. Then sit down. So I'm not going to talk about, I'm just going to build up on what my colleague doctor have talked about. And I'm going now just to build up. She talked about one rescue. So I'm going to come in when you are two of you. She said she had witnessed cardiac arrest, and she said it's a very, very tiring task. So most of the time the hospital setup, you will find that you are not working alone. You are working as a team, okay? And we said basic life support is just a measure that you are carrying on as help is coming. And which are these tasks that we are carrying out as we are waiting for help? Which are these tasks?
Resuscitation.
What does it entail, this resuscitation? What is BLS? It's very basic. And she talked about those three things. What are we dealing with? Yeah? Circulation, yes. What's the other thing? Breathing. What's the other thing? Airway. Okay? It's airway, breathing, circulation, defibrillation. That's all about BLS. We don't talk about drugs, okay? In BLS. In drugs, we are going to do a course called ACLS. That's where you will find drugs and other measures like intubation. But in BLS, this is just a life-saving measure that you are taking in anticipation that you've called for help and help is coming. And we talked about chest compressions are very key. And we said you have to know how to do them. High quality CPR, which we said that it's inclusive of this high quality CPR. What is it about? High quality CPR. What's the one? There's no wrong answer. You talked about them, I'm just recapping. Push hard and fast, isn't it? At a rate of? Rate of? 100 to 120. What was the other quality of high quality CPR? Minimize interruptions. Less than 10 seconds. You have seen that the moment your hand is off that chest, okay, you are reducing the chances of survival because there is nothing, the heart is not pumping. And the vital organs, the brain, the heart, they need this oxygen. And this oxygen, the only way that you can push it to the rest of the body is through these compressions. So if you stop those compressions, those few minutes or few seconds that you are not on that chest, there is no blood supply, there is no oxygen to the brain, to your heart, to your vital organs. So it's very key. Minimize interruptions. That's why she said, like, once you do an intervention, let's say like you have shocked, you deliver that the AED have prompted you to deliver a shock, you immediately resume chest compressions. You don't want to go checking for pulse, okay? So you want as much time as possible. You want to be on that chest. If it's not 100%, 80%, be on that chest. And that's how you are going to give this person a chance to survive. I give a scenario. There's this patient, you are walking home, you have collapsed. You have initiated CPR, and she also said that she has called Aga Khan Hospital, and they'll be coming. So she's just waiting. But the patient will go to Kenyatta. He's already booked a bed in Kenyatta. Who has the best chance of surviving? The one who will go to Aga Khan or MP Shah, or the one who is being done CPR and is going to Kenyatta? Sindio? It's the one going to Kenyatta, Sindio? Okay? So, it doesn't matter where you go, but the steps that you take, how soon you start this resuscitation. And we said, immediately recognize, and you have to recognize. And how do you recognize? How do you know that a patient is in cardiac arrest? What are the signs that a patient is in cardiac arrest? Yeah? Yes? There's no pulse. That's one. What's the other thing? No breathing or agonal breathing. Okay? Or the patient is unresponsive or unconscious. So those are the things that will prompt you. Like here, this is not a thing to joke. This is an emergency. I need to call for help. I don't have time to waste. I need to activate, because this is an emergency. It's a cardiac arrest or an impending cardiac arrest. And she said, mostly in the hospital, what we do, we want to prevent before it occurs. And you can see, probably your BPs are low, probably your oxygens are going down, then you can make measures. But if you're not able and you're now in the arrest situation, then you just activate immediately. And whether you are 2, whether you are 10, whether you are 5, these steps remain. Okay? And this is what we'll be singing in our practical sessions. When you're doing, this has to stick. If anything you forget, this one, please don't forget about this. Okay? So we said the first thing is safety. Okay? Safety to yourself, safety to the patient. Okay? And we said safety is not just about the environment. It can be many things. Okay? It can be rooftop fire. Okay? And also we said PPEs are also part of safety. Hazard, don't become a victim yourself. So you need to ensure you are in proper gloves, you have put on your gown, okay? Protect yourself first. So you have ensured, if the patient or it's an accident on the road, move that patient to a safe place. Otherwise, ukifanya resuscitation kwa barabara, una save time, si utakuwa victim. Sindio? So ensure you are safe. Safety cannot be overemphasized. Then we said stimulate. Okay? So you can start with a verbal. If you know him, call him by name. Maina, can you hear me? Joseph, Lydia, can you hear me? She's not responding. Tap on the shoulders. You can pinch. Tap, can you hear me? Can you hear me? He's not responding. So what's the next thing? He's not responding. Shout for help, okay? And shouting for help, we said it has to be very objective. What's your name?
Kweku.
Eh?
Kweku.
Kweku,
yes.
Kweku. So Kweku, go get me an AED and come with a Nambu bag, okay? And activate for the 911, or if you have a code blue, a number you dial, then you dial, isn't it? Then you are 2 of you, okay? So you are left there with the patient. So what's the next thing you do when you are left with the patient? Someone has gone to get an AED and activate for the 911 or the code blue number. So what's the first thing you do? Check for pulse. And we said for adults, where are you checking for pulse? Yeah? What's that? Carotid. So you checked. We'll see some with clear, some with blue. We'll see that on the practicals. Okay? But there's an issue of blue just on the neck. There's kuna kamtaro hapo. Between your trachea and the sternocleidomastoid muscles, there's a small groove there, okay? So some are a bit obese, so you may need to press a bit hard. But we always say, if you're not sure, I can feel kama iko, kama haiko. If you're not sure, just work with, there is no pulse. Work with that. It will be more safer than there is no pulse. Okay. So we've checked there is no pulse. What else are you checking at the same time? Breathing. Okay. You're looking for chest rise and or movement. Okay. So at the same time you're checking for. So you don't now finish your pass and go to your. Okay. So simultaneously. So simultaneously you're checking for pulse and you're checking if there is chest raise. Long time used to check, as I was saying, look, listen, feel. So it's no longer there. It's wasted. The studies showed that we are consuming more time trying to listen and all that. So you just check: is there chest rise? There's no chest rise. There's no pulse. Straight in, you jump to chest compressions. Okay. All right. So we've talked about the high quality CPR. Okay. 30 to 2. Okay. Push head and fast. What depth? 2 inches for adults. For child. We'll talk about child. Don't confuse. Someone will talk about that. So for adults, we said 2 inches. Okay. That will be how many centimeters? 5 centimeters. Okay. All right. So 2 inches is equivalent of 5 centimeters. Then another thing on compressions, we said minimize interruptions, push hard and fast, allow chest recoil. Okay, the same depth you went in is the same depth you release, so that the blood is filling up. Okay, that's the logic. If you're just compressing, once you release, you allow the blood now from the inferior vena cava, superior vena cava to come back in, then you push it out. Okay, that's why you're allowing time. But if you're just doing like this, there is no time for blood to fill up the chamber and then push it to the side. All right, good. So you started your compressions. You've done your that. Then you go to the airway. We talked about the maneuvers of opening the airway. Which are they? Which are they? Jaw thrust. When do you use jaw thrust? When you suspect cervical injuries. Okay? So use head tilt, chin lift. Okay? So you do your head tilt, chin lift, then you give your breaths. Okay? How many? 2 breaths. Okay? So 32 2 breaths. Okay? Each breath lasting 1 second. And what will tell you that you have given an adequate breath? Chest raise. Just once you see chest raise, you are good. You don't need to press the whole bag. So once you squeeze that bag and you see a chest raise, you are good to go. You are doing an awesome job. Okay? So you have done that. Someone went to get an AED, so he's back. And we said, what is the AED? So you might not find an AED in the hospital. You might find a defibrillator. Okay? But for basic life support, we don't talk more about the defibrillator. We talk of AED. but they work the same. But an AED has less functions compared to a defibrillator. One of the advantages of the defibrillator, you are able to titrate your energies. You are able to regulate your energy, like how many joules to give. But for an AED, it can't give you that option. It will just deliver a shock, and that's it. Okay. So we said what AED stands for. Automated external defibrillator. So I need 5 scenarios where you want to use a defibrillator. Someone on the back benches. Special like measures you need to take that you can't just use directly. Yes, yes. Like when can't you use an defibrillator on a patient? Yeah, like immediately you find this. No, this one I need to push back and do something. Yes?
The patient has a pacemaker.
A pacemaker, good. Okay? So you can use it, but don't place it on top of the pacemaker. So if your patient has a pacemaker, you can use, but don't place it on top of the pacemaker. Okay? The other one? If the patient is submerged in the water, this is electricity. Okay? In a steamer. So if the patient is in a pool of water, you need to take this patient out of water, okay? Put him somewhere dry. But if it's just small paddles, so just wipe dry. Just wipe dry that chest. And you place the paddles. If the patient is having hairy chest, you won't be able to shock this patient. It will keep telling you, check your pads, check your pads. Check your pads. Okay? So you need to shave. And if you don't have time to shave and you have an extra pad, what happens? Yeah? You have an extra pad in your bag and the man is so here, I do not forbid this. Yeah? So there. So you just press that pad and rip off. It comes with hair. And then now you apply your new pads. You are saving life. You can live with that. But you save that person. Okay? It happens, but ensure that you have an extra pad. Ensure you have an extra pad. Don't use whatever you have to rip off and now you can't use it. Okay? Because we said in adults, most likely, like 90%, you find that the cause of arrest was an arrhythmia, which will talk like possible shock arrhythmia, the rhythm that defibrillator is going to terminate. Most of the time, 90% or 100%, it's usually those abnormal rhythms. Even if you do your CPR very nicely, you're not interrupting, and you didn't shock, you won't achieve your ROSC, or spontaneous return of saturation. So you need this electricity. Okay? So once you have attached a patient who is bare chest, don't put on top of clothes. It should be on a bare chest. Okay? We'll see that on when you're doing the demos. Okay? How do you place them? Okay? Which area? They're usually marked, well marked, which is the posterior, which is the one you place on the clavicle. Okay? So you'll see that. So you place them nicely, and then you put on them on. You'll go that step. It's so self-explanatory. But when you come with an AED, the first thing is you put it, plug it on. Sawa. If you come with an AED, okay? If it is the one without the lid, if it is the one you open, then you have, the first thing you do is put it on. So, don't forget that. When you come, don't start attaching the leads. So, put it on first. Don't forget. That's the first thing. You have the AED with you? Here it is. So the first thing you come is put it on, okay? Then you fix and you attach your leads on a bare chest. So, but we'll do demonstration for that.
Sorry.
Yeah.
What if the patient has piercings?
Huh?
Piercings on their chest.
Piercings.
Yeah.
So just don't put direct. Don't put direct. And mostly I know most of the piercing are on the nipples. Yeah, I know. So you find that so like this, but we do, I don't know how you place them. So one just do the clavicle, just the other one just do the left nipple line, just below there. Okay. So she talked about using of the AED. Never use a pediatric part on adults. Never ever. But you can use adult on, but just ensure they are not touching one another. Yes.
What's the logic behind the placement of the parts?
It's just the flow of current. You see the current flow. Okay. So when you shock, you like encompassing the heart. Yeah. So that current just stuns the heart. Okay. Because what usually this is electricity, and that's why we'll be very keen. Observe it. If you are like it tells you clear, do not touch the patients. If you start touching, you can be shocked or you'll be electrocuted. In a steamer, don't joke with this. Or you have the DP. Please, if it says clear, stand. You can even lift your hands like I'm clear. Okay, I'm clear. Okay. Shocking, shock advised, shock delivered. Resume compressions. Okay. That one, don't joke. If it tells you clear, clear, please. See my like something to make you worry or it's true electricity. It'll shock you. You'll become a victim. So you're part of thinking. So that's it. Any question before we go for break? Questions? Any question? Yes. The right clavicle and the one on the left. On the left, just below the knee. Yeah, but for the parts, if you're using a defibrillator, always ensure there are those which don't have parts. Don't stay with those things like this. I'm waiting to shock. Huh? You forget or feel like scratching. Any question? There's no Yes. So for BLS, as we are just waiting, so you continue, it is still shockable. Continue shocking. How many shocks? You continue, it is still shockable, you shock.
Is there a maximum? Is there a maximum amount of shocks?
No. It's not like, it's still shockable till the machine will tell you, analyzing, shock advised, shock given. But now also one of the things that an indication for termination of resuscitation is fatigue. Sometimes if you get fatigue,
That's what you call time of death.
yeah?
That's what you call the time of death.
You have to push. But now the problem is they are there, you can't even, you're just too tired. And more so the compressions. This one is fine. It's just about the compressions are usually there. You're just there, you can't, you're basically doing that. So you're not helping the patient.
So after 4 minutes on the brain, there is statistics.
Not really. Some in the hospital center will probably go even for now.
What?
Yeah.
But you're switching.
Yeah, we are switching. And that's why we said call for help early. Call for help early. If you don't call for help, you are doomed. Because no one will come and assist you. Whether you get tired. Yeah, but as she said, like some of those scenarios, there are those which like most of the like unwitnessed, we might now like do for 2 minutes or so for the patient, then go get help. Yeah, first resuscitate, but if you witnessed, you can just go and get help. Any other questions?
Also, like, is there a specific like hotline for emergency healthcare in Kenya?
Just 911, 999, 999. Yeah.
When you say
Unless now you have the numbers for St. John Ambulance, the Ambre, E+. Yeah, you should just like have that number already.
Okay.
Fire station, the ambulance number. Those numbers, there's a call. You should have them. They're very so you can go for tea.
Okay. We are done with that phase. We want to break briefly and then come back for 2 sessions. John will be presenting and then he will talk about team dynamics. Then we do the self-assessment. Then we break into the practical sessions. Melvin, you want to say something about this session?
So John has sent the link to the group.
it's not loading. It's been loading for like the past 10 minutes.
Try lifeplus.co.ke.
That's the one. So we've registered our names, and then after that, when we click, it's just been like this for the past 10 minutes.
Okay, interestingly, we have the expert on that website. So let's do this. Let's break, come back, as we try to find out where the challenge is. Is that okay? How much time?
20.
20 minutes. Yeah. 20 minutes. You can walk around if you want. Okay. If you want to handle it.
Oh, no, 30.
No, let's see to 20.
25.
Unless you want to leave at 7. All right.